Okay, we're streaming. We're going to go ahead and broadcast, invite everyone in. Okay, Mohammad, I think we're ready to get started.
Hello, everyone, and welcome to our roundtable, Cities, Social Equity, and Pandemics in History. I'm Mohammad Gharipour. I have a PhD in architecture from Georgia Tech, and I'm currently professor and director of architecture graduate program at Morgan State University in Baltimore.
And I'm Caitlin DeClercq, one of the organizers of this roundtable. I earned my PhD in architecture from the University of California, Berkeley, and I'm currently an assistant director at the Center for Teaching and Learning at Columbia University in New York. Today's roundtable is part of our Epidemic Urbanism Initiative, which Mohammad and I founded in response to COVID-19. Our goal with this initiative is to explore how the outbreak of, response to, and lasting impact of epidemic illnesses help us understand urban environments and communities. As part of this initiative, we have organized two previous online symposia. The first, Epidemic Urbanism Reflections on History, held May 28th and 29th, consisted of 18 presentations that explored the historic pandemics from the 14th to 20th centuries, how they affected urbanism and the built environment, and implications for our understanding of and response to COVID today. The second symposium, convened in partnership with the Global Architectural History Teaching Collaborative, or GAHTC, last Friday, July 24th, titled Global Visions on Cities and Historical Pandemics, extended these ideas. 13 scholars presented historical case studies from diverse geographies, from the Philippines to Vietnam, Senegal, Nigeria, Brazil, all of which explore the story of an outbreak of an infectious illness, its impact on urban life and urban forms, and amplify the complex relationships between colonial and imperial power, public health and practices, public health policies and practices, community spaces and practices with pandemics past and present. So a primary finding of our work so far is the need to recognize the ways in which pandemics past and present exploit and amplify social inequalities, and really the urgent need for scholarship and interventions to work toward more critical, just, and equitable solutions. So this in mind, we've convened today's roundtable discussion to focus on the intersection of pandemics and social equities or inequities, and to do so by looking across various timescales, geographies, and disciplines. In so doing, we hope to explore the following questions. And of course, these are just a few of the many questions we hope to provoke today. What lessons can we learn from past pandemics? And of course, COVID included, about the relationship between health and equity or social inequity. How might these insights help us better intervene in the post-COVID world? And what are some implications for us as planners, designers, educators, researchers, scholars to that end?
Before we begin, we want to give a special thanks to Dr. Ruth MacKay and Emily Webster for accepting our invitation to moderate this session, and to our panelists and participants today. Ruth MacKay is a scholar of early modern Spain. She holds a PhD from the University of California, Berkeley, where she taught as an adjunct professor of history. She has written 4 books about different aspects of Castilian political and social history, including Life in a Time of Pestilence, the Great Castilian Plague of 1596 to 1601, which was published in 2019. Emily Webster is a PhD candidate in history at the University of Chicago. She works at the intersection of health studies, environmental history, urban history, and imperialism. Her dissertation project, Land Use Change and Interspecies Epidemics in the British Empire, is supported by the Social Science Research Council and the National Science Foundation. The format for today's session will be as follows. Our panelists will begin with brief remarks to articulate what their research provokes about the relationship between racial, social, economic, and gender-based disparities and health, with special focus on pandemics, past and present. After that, Emily and Ruth will offer brief remarks and engage panelists in a discussion, and the session will conclude with a moderated Q&A. We invite your questions in the Q&A box and in the live chat on YouTube. and we will try to respond to as many of your questions as possible. Finally, a recording of this session will be available on our Epidemic Urbanism YouTube page. And now, Emily and Ruth, the floor is yours.
I think you're on mute, Ruth. I don't know if you wanted to talk first.
No, go ahead, go ahead.
Well, thank you all so much for joining us. We're excited to have this panel, this roundtable convening on the issue of social equity and COVID-19. And I think we are going to go right into introducing you. Ruth, do you want to read the bios or should I?
No, please go ahead.
Okay, let me pull them up. So today we are joined by Malo, Hutson, Daniela Sandler, Anne-Marie Akehurst, Edna Bonhomme, and Carlo Trombino to talk about social equity and COVID-19. So I'll just read each of their bios quickly, and then we can get into discussion, unless we want to go in a particular order. Let's see. Ruth, do you have feelings on this?
They were listed in alphabetical order, and I think that's probably the logical way to go. Okay.
Okay, let's do that then. So, Edna Bonhomme is a historian of science, lecturer, and writer whose work interrogates the archaeology of post-colonial science, embodiment, and surveillance in the Middle East and North Africa. A central question in her work asks what makes people sick. As a researcher, she answers this question by exploring the spaces and modalities of care and toxicity that shape the possibility for repair. Using testimony and materiality, she creates sonic and counter archives for the African diaspora in hopes that it can be used to construct diasporic futures. Her practices trouble how people perceive modern plague and how they try to escape from them. Edna earned her PhD in history from Princeton University in 2017. She's a postdoctoral fellow at the Max Planck Institute for the History of Science and currently lives in Berlin, Germany. Her work has been performed and exhibited in Berlin, Prague, and Vienna, and she has written for Al Jazeera, The Baffler, The Nation, and other publications. Daniela Sandler is an associate professor of architectural history at the University of Minnesota. She's a PhD in visual and cultural studies from the University of Rochester. Her work explores social inequalities in the built environment and how groups and individuals fight for more inclusive cities through the bottom-up tactics. Her book, Counter-Preservation, Architectural Decay in Berlin since 1989, Cornell University Press, 2016, deals with alternative approaches to preservation, memory, and gentrification in the German capital. Her book received the 2019 Antoinette Forrester Downing Book Award from the Society of Architectural Historians. She's currently working on a book manuscript on grassroots urbanism in Sao Paulo, Brazil, which includes communities' responses to the COVID-19 pandemic.
I can step in and do Malo Hutson. I just found I had lost the bios, I confess. So Malo Andre Hutson is an associate professor of urban planning in the Graduate School of Architecture, Planning, and Preservation, and an associate member of the Earth Institute faculty at Columbia University in New York. He has published extensively in the areas of urban planning, urban health, racial, social, and economic justice. His PhD is from the Massachusetts Institute of Technology, MIT, and his bachelor's and master's degrees are from the University of California at Berkeley. He is a former Robert Wood Johnson Health and Society Scholar.
Wonderful. And then Anne-Marie Akehurst is an independent architectural historian, is affiliated to RIBA, and is the programs officer and trustee of the Society of Architectural Historians in Great Britain. She obtained a PhD in architectural history at the University of York, where she taught art history for several years. She writes and publishes research on early modern architecture of sacred space, on civic identity, and on healthcare in the UK. And last but not least, certainly, Carlo Trombino is a PhD student at the University of Palermo in the Department of Culture and Society. He holds an MA in history at the University of Bologna. He's currently working on a multimedia research project on the 16th and 17th centuries Mediterranean slave trade with a focus on Mercedarian order and the redeeming institutions in Sicily and Catalonia. Thank you all so much for joining us. And to get started, I think we're going to have Anne-Marie tell us about her work.
Thank you, Emily. Can everybody hear me? Thank you to Mohammad and Caitlin and to GAHTC for inviting me today. I'm conscious that I'm speaking from England, and I'm expressly using England rather than the United Kingdom because this current emergency has somewhat fractured the unity of that polity. England has just had revealed that it had the highest excess deaths in Europe, so it's not a great. We haven't had a great outcome here, and I decided that I would call this talk "We Are All in This Together: Liberties and Pandemics, 1665 and 2020. London remains two cities divided by massive wealth inequalities. Striking parallels between the 1665 Great Plague and 2020 suggest that extensions of the political franchise haven't changed traditional power structures. Yersinia pestis, the bubonic plague, carried by rat fleas, arrived in spring, and London lost over 100,000 souls, that's 7,000 in 1 week alone. Plague kills indiscriminately, but insalubrious housing and lack of escape rendered poor people more susceptible than highly mobile elites. The diaries of the courtier John Evelyn, Admiralty Administrator Samuel Pepys, and the saddler Henry Foe document the outbreak. I'm concentrating as an architectural historian on freedom and access to spaces because epidemics affect individuals depending on exposure. 450 acres inside London city walls and wooden shanty suburbs housed 500,000 people. Bisected by the River Thames, it comprised the financial city of London and liberties, independent ancient walled precincts, bubbles, if you like the Tower of London. Westminster, an independent town with its own liberties, adjoined London by urban development. Housing the king and court, Westminster was the locus of political power at Whitehall Palace, Westminster Abbey, aristocratic and episcopal palaces, and inns of court. Their airy precincts lined the Thames. Travelling by carriage isolated powerful people from disease, though most, including doctors, lawyers, and merchants, fled to country estates. The Queen Mother left for France. King Charles visited Hampton Court, Wilton House, and Oxford, where Parliament reconvened. The universities closed. Isaac Newton quit Cambridge for Woolsthorpe Manor, and Oxford colleges owned retreat houses. Such freedoms meant Evelyn's pregnant wife escaped to their Surrey estate, leaving him in Deptford. Pepys removed from his house in the Liberty of the Tower to Woolwich. Elite freedom contrasts with His Majesty's poor subjects. London City was densely packed with medieval timber buildings. Great houses had become overcrowded, rat-infested tenements where hygiene was impossible. People walked rubbish-filled streets, encountering excrement and the rats it attracted. Filth was removed to mounds where it decomposed. A royal proclamation established long familiar strategies, halting public gatherings, imposing disinfection, restricting movement. Pepys and Evelyn noted the bills of mortality, that's the records of deaths every week, and expressed shock at those deaths. But plague infringed their liberties less than those whose employment and movement were restricted for the public good. The Lord Mayor and Aldermen remained to enforce the orders and limit the spread. Infected families were nailed into houses marked with a cross for 40 days and surveyed by watchmen. Non-compliance was severely punished. Key workers, like bakers, were compelled to continue. Markets were plentifully stocked, but trade stopped. Plague disproportionately affected people whose livelihoods and networks were local, yet quitting London required unobtainable certificates of good health. Refugees scavenged and slept rough, but they encountered suspicion and hostility from fearful villagers. Meanwhile, elites continued running the country. Legal cases relocated to Oxford, and the Exchequer, that's the Treasury, to Surrey. Evelyn surveyed St. Paul's Cathedral with Sir Christopher Wren. Then there's Samuel Pepys. England was fighting the Dutch, so his Admiralty role took him up and down the Thames in a yacht, isolating him from plague, so he partied at night. Pepys, by his own admission, had a really good plague. COVID exposes identical inequalities in English society affecting housing, education, and health. Despite the United Nations reminder, we are all in this together, COVID exposes elites' identification as separate from the public. While age is the biggest indicator of COVID vulnerability, clinical outcomes are poor for people with obesity, diabetes, and respiratory conditions associated with poverty. Multiple occupation housing facilitates transmission. Contemplating health-wealth trade-offs, government policies have not always aligned with the public's relative valuation of health over wealth. A herd immunity strategy anticipating 500,000 deaths was ostensibly abandoned, though some scientists argue it still shapes policy. Despite the mandate to protect the NHS, England's hollowed out welfare system sacrificed many low-paid health workers through PPE shortage. Vulnerable groups are mandated to shelter in place. Sealed care homes for elderly and disabled people generate social isolation. And Malthusian policy denied elderly patients hospital beds, discharging them to institutional homes staffed by non-elite carers without PPE and testing, where COVID annihilated them. The Prime Minister's father enjoys his Greek holiday home, while bewildered dementia sufferers are incarcerated in institutions made hotspots through government neglect. Education underpins English inequality. Elites weigh evidence-based risk assessments, while non-English speakers struggle with apocalyptic rhetoric and complex information, and uneducated people propagate and act on deep fake news and conspiracy theories. Fee-paying schools erect alfresco classrooms on extensive grounds and broadcast lessons, while poor families struggle to home educate in cramped surroundings with shared devices. Elites embrace Zoom in home offices, I'm afraid, commission gyms and alfresco kitchens, replace domestic help with robots, and support mental well-being with attractive interiors. For others, lacking access to alternative spaces, domestic violence has exploded. Travel to second homes enrages. Despite legislation to stay at home, ambiguous messaging reserves wiggle room for cognoscenti. The Prime Minister's special advisor drove his infected family 300 miles on a pretext with apparent impunity, igniting outrage at elite exceptionalism. By contrast, many key workers fearfully rode public transport unprotected to their essential compulsory employment. That manifestation of one law for the rich, amplified by the Black Lives Matter protests, has provoked outrage and undermined compliance. Yesterday, parts of northern England with large Muslim populations were locked down hours before the Islamic festival of Eid, prompting accusations of racism. Thank you.
Thank you so much, Anne-Marie. Next up, we have Malo Hutson.
Great. So thank you so much, Anne-Marie, for that wonderful opening. I want to build on a few points that Anne-Marie made and hopefully cover the context, certainly what's been happening in the United States. But I want to start with my research, and it's really at the intersection of urban planning, community development, and health equity. So I'm quite concerned about how the built environment, whether it be housing, transportation, economic opportunity, and just the physical space itself, how that impacts people's lives from whether it be mental health, physical health, and just the overall social well-being for people. If we look at the United States, certainly what's happened with COVID-19 is mirrors very much what Anne-Marie described with earlier pandemics. You have to look at the history, certainly in the United States, of our history of residential and racial segregation, economic segregation, and who really gets impacted by these types of events. And so thinking about the US more broadly, but even with New York specifically, where I live now, we see how New York City has been hit certainly hard. And what we've seen is who's been impacted by this, who's disproportionately been impacted by COVID-19. Certainly the earlier reports that came out in the media was people of color with underlying conditions, or those with underlying conditions. And what we didn't do is describe and dive into, well, what does it mean to have an underlying condition? Where do these conditions come from? And so as we think about the history of our cities and the construction of our neighborhoods, it's not as though they just, were created in a vacuum. In fact, we had laws, policies, and practices that have contributed to our cities. And the same goes to when we start to think about health equity. So in the case of COVID-19 and New York City, you have to look at the spatial inequality of the city, of all of our cities, certainly across the United States, and see who lives where. And what we found, obviously, is that, or not obvious to some people, but certainly for researchers like myself and those who are watching today and my colleagues on the panel, is that spatial inequality exists. And as you start to look at whether you map from an economic development perspective or a demographic perspective, you'll start to see the areas that are been impacted largely by COVID-19 are those same areas where you see people of color, whether it be Blacks, Latinx community. And it highlights this wealth-poor divide that Anne-Marie discussed just earlier. But you have to look at who's doing the work. So we say stay home, quarantine. And in fact, if you look in New York City, 75% of our frontline workers are people of color. They're the people working at grocery stores. They drive our transit. They are doing driving for Uber or Lyft. They can't stay home. And even in situations where they are at home, we have to think about the situations around overcrowding, the kind of poor conditions of our housing for those who are poor. And so you have to unpack many of these things. So in my own work, I've really looked at the spatial inequality around COVID-19 and what's been happening, but certainly looking at the racial and social determinants of health that have been discussed earlier, but looking at poverty and inequality, the inadequate supply of affordable housing, and certainly in a place like New York or London or any other really expensive place, San Francisco, around the world, you see the poor trying to survive, trying to stay in place in order to work. And so it highlights a whole host of inequalities in our society, gender inequities of thinking of who does not the labor within the home, who takes care of the children, the issues that the role that education plays in providing childcare for many families that don't have the ability to afford extra childcare or have that extra support where they can pay for a childcare center or whatnot. And then we have to look at the broader systemic issues within our society, certainly the lack of investment within these communities, but the lack of access to things as simple as medical care. And I say simple because of the fact the rest of the world has, certainly our equals around the world already understand the importance of access of healthcare for everyone. And we still struggle with that, certainly in the United States, but in also just medical institutions and hospitals and so forth. So we've seen this play out over and over. One of the things that I just want to touch on before I pass it on to my other colleagues is going back to this issue of the health-wealth divide. We have seen, certainly in the case of New York City, the wealthier families have been able to leave. They've gone out to their suburban homes or to their vacation homes, or they have that second home. They have the ability to stay in place. And the fact of the matter is, if you look at who's providing the services, again, it's the people of color, and not having access to proper working conditions, not having access to employment insurance. You probably understand what's happening right now of the big debate in Congress of whether we should extend the support for those who are out of work, and certainly providing people with the proper housing relief that they need. And so we're running into a number of issues here, and certainly the history of residential economic segregation within our country in the United States has really contributed to these inequalities that we see certainly around COVID-19, and has highlighted the problems within our system. So I'll stop there, and we'll come back to that through the discussion. Thank you.
Thank you, Malo. Next up, we have Daniela.
Can you hear me okay? So thanks everyone for having me. And I'll pick up on some of these themes, but bring a historical perspective. And so my research is on different epidemics in São Paulo. I am looking at COVID, but I'm actually going to focus today on an older epidemic and what kind of lessons it might offer for us today. And that was an epidemic of meningitis in the 1970s in São Paulo, which has some eerie similarities with COVID and also some important differences. And so that epidemic started in 1971 in the city, and it lasted until 1977. It was meningitis, bacterial meningitis, a very scary disease. The lethality is higher than COVID. It was a very scary epidemic. It took a while to be brought under control. And it brings up important questions about inequality in the city. That particular epidemic started in 1971 in a very low-income neighborhood in São Paulo. And one thing that I want you to keep in mind about São Paulo is that, unlike many American cities, the outskirts of the city, the peripheries, are the low-income areas. And the wealthier neighborhoods are in the middle of the city, and they tend to be older, more established neighborhoods. So it's important that this epidemic started in the periphery, where questions of social inequality, income inequality also overlap with issues of race, gender, and other challenges. So then the peripheries of the city, that's also what I want you to understand, were areas of the city of recent urbanization compared to the rest of São Paulo. They started to grow in the 1950s, and their growth exploded in the 60s, 70s onward. And they were growing super fast, in part due to migration from other places in Brazil, from the rural areas of the state of São Paulo and from poorer states in Brazil, because São Paulo was a powerhouse. It had jobs in many different fields, industry, construction, services. And so you have this huge influx of migrants. And in those neighborhoods, which were the fastest growing in the city, that influx of migrants counted for more than 60% of the population growth. So they're growing really fast, but when they're moving to those neighborhoods in the periphery of the city, there is no neighborhood. There was nothing. They weren't really part of the city. They weren't connected to the city systems because they were on the outskirts. And so these people, when they arrived, they had to build not only their homes with their own hands, but also their neighborhoods. Some of these neighborhoods do have shanty towns like favelas, which maybe you have an idea in your mind, like really precarious conditions, but they're not all considered favelas. They're neighborhoods, but they're very precarious. And so they didn't have sanitation, they didn't have public transportation, they were super far from health clinics or health services, no access to education, and the people who lived in those neighborhoods who were very, very poor and had jobs all over the city, had to go into public transportation, spend hours in many crowded buses to get to their jobs elsewhere in the city. So their bodies were traveling around the city. So now going back to the epidemic of meningitis, many experts, epidemiologists, doctors, consider that epidemic started precisely because of the influx of migrants into the city for a variety of reasons. And when you look at the path of the epidemic, it started to go around the city in concentric circles, starting with the outskirts. And so the first regions that were hit were those very poor, precarious peripheries. But the epidemic kept growing. And every year it would encompass more parts of the city with these concentric circles that kept circling into the center. And in 1974, so 3 years after it started, it basically was everywhere in the city, including the wealthier areas in the center. By that point in time, that was the worst year of the epidemic by far. You had two different serogroups of the bacterium, including serogroup A, which is super aggressive. It was terrifying. Everybody was panicking. But what happened at that point, which was a turning point in the epidemic, is that up until then, the epidemic, like the government wasn't doing anything. Brazil was under a horrible military dictatorship, which kept everything under wraps. There was no collection system for even knowing how many people were sick or dying. Whatever information there were doctors trying to sound alarms and journalists. It was all censored and kept under wraps, and the government just basically didn't care because it was poor people dying. But when it got to the center of the city and the middle and upper classes were also getting sick and dying or being scared, like parents, children were very affected. So parents were really scared. Schools were closed, all that kind of stuff. So then that was the turning point. And so in 1974, first of all, you start to have a lot more news about that in the press, despite the censorship. So people start to know what's going on. It was very difficult to hide the situation by that point anyway, because the one hospital that treated 90% of the patients was overcrowded. But what started to happen is that finally the government decides to make a plan. By this point in time, the epidemic is not only raging in São Paulo, but also spread throughout the whole country. And so the government decides that the plan was going to be a vaccine. So everybody pinning their hopes on a vaccine. Now, and that's when it gets also interesting for us to understand the current situation. There was already a vaccine for meningitis, for those types of meningitis, but it had never been produced at such a large scale. Brazil had about 100 million people at the time, and the government wanted to order 80 million doses for the age groups that were going to receive, which I think was everybody over 2 years of age. And so there was one lab in France that made this vaccine. So Brazil ordered at an enormous cost 80 million doses of the vaccine. They had to build a facility to make the vaccines in France. So that all started in 74, and then by March 1975, the vaccines were ready and they could be shipped to Brazil. And there was a huge vaccination campaign. In the first 5 days of the vaccination campaign, they managed to vaccinate about 10 million people, which was larger than the population of the city of São Paulo of the time, which had about 6 million people. In 10 months, they vaccinated 80 million people in the country. It took still about 2 years for this disease to go back to endemic levels after that, but it did. And I'm very glad for the vaccine because I was born in 74, which was the worst year of this epidemic, so I'm grateful. But I'm going to conclude with this one point, is that the thing about the vaccine, that was the one bet of the government. And it obviated the need for any other kind of intervention that would have been more long-term and more prescient, such as addressing the super inadequate housing conditions in those peripheries where people lived in very small dwellings that were overcrowded. The estimate is that it was about 4.4 people per dwelling in the peripheries, but those dwellings were usually like a one-room dwelling where you had entire families crammed. And so nothing was done to improve the quality of housing, to bring public transportation, health clinics decentralized in those peripheries, to improve sanitation, to improve education or preventative medicine. And so the vaccine solved that crisis. But now fast forward to COVID, and you can imagine that all of those conditions that made it possible for the meningitis epidemic to start and to develop and progress at such a horrifying rate, those same conditions are not only still there in the peripheries of São Paulo, they have become worse. And I'll conclude with this one sad thought, which is unlike with the meningitis epidemic, when it started in a low-income neighborhood for a variety of factors related to that disadvantage, with COVID, it started with the wealthy neighborhoods because it was introduced in Brazil late January, early February with travelers from Europe and the US, which are people who are wealthy and live in the wealthiest parts of the city. And those were the first cases. But poverty is intertwined with everyday life in Brazil in many ways. And so the people who live in the peripheries, they work in the central areas of the city. They are maids and nannies and janitors and service workers. And so quickly, that disease spread through those bodies, through public transportation, transiting around the city, to the peripheries. And now, as you can imagine, the peripheries are by far, with very few exceptions of success grassroots stories, peripheries are by far the most affected in terms of cases and deaths, whereas the wealthier parts, although affected, have been able to manage, as described, also for very similar to the US and the UK. So I'll leave it at that, and thank you.
Thank you so much, Daniela. Next, we have Carlo.
Hello, everyone. My first presentation on the first Epidemic Urbanism Online Symposium was on the Plague of Palermo in 1576 and its management by great epidemiologist Giovanni Filippo Ingrassia and how we saw urban planning as an effective tool to fight both a pandemic outbreak and social inequalities. Today I will talk about how much epidemics influence human movement inside the cities, but also movement between different cities and nations. The way in which human movement is managed by authorities can influence both the effective public health response to the disease and also the pre-existing social inequalities. This can be seen today in 2020 and both in the 16th century. During the 16th through 18th centuries, all the ships coming to Palermo had to quarantine, especially those coming from areas stricken by epidemics. That was something normal. It meant that all the expenses to sustain the crews and the passengers in the port for quarantine were always planned in advance by merchants, ship owners, and public authorities, well before selling off. But somehow this year, this same basic hygiene protocol has been implemented with extreme difficulty by Italian government during this COVID pandemic, or at least it is implemented in a way that is making explicit the social class and race divisions in modern Europe. As Dr. Richard Jackson recalled in his review of our past panel, the hygiene measures we have to enact in this pandemic are pretty much the same of those applied in the 16th century, with the significant differences of today's astounding advancements in medical science and technology. This fact makes it even more unbelievable what is happening today here in Sicily when ships are, migrant ships are not immediately arranged for quarantining migrants, while at the same time, hordes of tourists from all over Europe can freely roam the island without being tested. The migrants from Libya and Tunisia arriving by boat in those days on the Sicilian shores have been often disembarked without testing, creating the possibility of contagion and creating alarm among the population, fostering racism and divisiveness. For example, in the southern Italian region of Calabria, there were protests of locals who didn't want the disembarking of COVID-positive migrants from the ships. Here in Palermo, a pregnant Somali migrant woman was taken to the hospital without testing her. And then it was discovered she was positive to COVID in the days following her hospitalization. The same thing is happening with seasonal workers from Bangladesh and Romania who are exploited to work in agriculture and petty commerce, who are not even tested or quarantined on arrival. In this sense, the Bangladeshi, Somali, Bulgarians, and Romanians that are coming to Italy on illegal migrant routes have not the means to safely self-distance given their condition of illegal migrants and or their subsequent life of semi-slave labor. While the rich French, Germans, or Belgians who are coming from infected regions are supposed to be able to avoid the contagion. But obviously it is not always the case, as is the example of a wedding of more than 90 people here in Sicily when a recently arrived person from Germany who was positive infected a lot of people, so it proved false. Also the living conditions and the urban spaces that migrants are living or are forced to live are increasing the likeliness of a contagion. From the Libyan prisons to European Union hotspots such as Lampedusa, the hotspot could host 90 persons and is hosting 1,000 persons in those days, to the shacks and slums where they're housed in the southern Italian plantations. All those facilities are factors in the spreading of the contagion. The Italian government decision to not test quarantine those coming from infected richer European regions made those illegal migrants the scapegoat for the public opinion, something that could have been avoided by simply applying the measures, hygiene measures put in action by Giovanni Filippo Ingrassia 500 years ago. But this is not the only racial and class divide that we can see being in common in those two pandemics, so similar yet so distant in chronological terms. The difference in how the anti-pandemic measures were implemented between rich and poor are an example. From the book of Giovanni Filippo Ingrassia, we know that in 1576, the poor were protesting against the government because robes and garments of the richest were simply washed and sanitized, while poor people's belongings were burned. Today, during the worst moment in March of the pandemic in the most hit Italian region of Lombardy, the residents were protesting because they were not tested enough, while TV stars, politicians, and football players got screened almost daily. This means that social status and class are extremely relevant, and pandemics can be an accelerator among social strata. As Professor Malo Hutson said, different social classes had different access to health tools. The difference between European well-off tourists and migrants, illegal migrants, is in the testing and in the public opinion is somehow similar of the parallel between the masses that were complaining during Ingrassia's time for being obliged to burn their clothes while the rich could avoid it, and not differently from the people from Lombardy complaining for the rich had tested way more than normal people. In this sense, the social epidemiology measures and urban interventions made by Ingrassia were addressing these exact problems that now we're facing with a lot more trouble. Because in this day, we should have the means to give patients what is needed, something that was obvious in the past centuries and somehow is being forgotten today. Thank you very much.
Wonderful. Thanks so much, Carlo. And finally, we have Edna Bonhomme. Go ahead, Edna.
So first of all, thank you so much, Mohammad and Caitlin, for organizing this panel, and to the co-panelists as well, especially for those who are providing some form of care work so that we could be here. Normally, my research focuses mostly on epidemics in the Middle East and North Africa, but since my postdoctoral fellowship, I've also been trying to understand how diseases and epidemics more broadly impact post-colonial subjects and racialized subjects, especially in thinking more deeply, not just in a Cartesian sense and methods of archival work, but also engaging work that looks at speculative fiction, Afrofuturism, and figuring out how we can have different possibilities for reorganizing space, health, and embodiment. So in this current moment of uncertainty, speculative fiction has especially become relevant in understanding crises and social inequities. And one particular author, our deceased author, Octavia Butler, is very much been popularized in this moment, especially her text, Parable of the Sower, which in that particular text, she looks at the ways in which forces of imaginations can birth a utopia. Nevertheless, it's also a text in which Lauren, one of the major characters, indicates, quote, "I am earth seed, anyone can be. Someday I will think that there will be a lot of us, and I think we'll have to seed ourselves farther and farther from this dying place," end quote. Given the current pandemic, the rise of the far right globally, imperial wars, and the focus of Butler's text and this particular quote echoes with some of the sentiments that people might be having in this moment. And since December and COVID-19 has spread globally, including here in Germany where I'm based, I think that part of what people are trying to reckon with is how the effects of the epidemics are not equally felt. One of the ways in which I'm trying to look at these intersections of the epidemics and social inequities is not just through the colonial legacies, but also through reproductive care. I do want to note that on an anecdotal area that I have several family members who have tested positive for COVID-19. So my mother, my sister, and it's important to note that mostly because various Black Americans or people who have roots from the United States happen to know someone who has tested positive, mostly because we disproportionately have family members who are essential workers, or in some cases, people who are incarcerated, or people who work in medical fields as janitors, cleaners, nurses, etc. So in a moment in which this pandemic is not only tied to massive inequality, but also anti-Black racism, which we see vis-a-vis police brutality and other forms of systematic inequalities, it's important to note how the health question and public health crisis is also reproducing a version of what Achille Mbembe refers to as necropolitics. That is to say, our human existence and bodily autonomy can be dictated by post-colonial relations as well as through racism. So one arena in which this is especially relevant is through sexual politics, reproductive care, and gender-affirming medication and surgery, and the ways in which it impacts Black communities. Even under normal circumstances, Black motherhood or Black parenting in the US is heavy, moving between feelings of hope and pride, feelings of fear. And as Black Lives Matter co-founder Patrisse Cullors indicated, being a Black mother means someone who, quote, has to carry the weight of having to protect her children in a world that is conspiring to kill them. And that consignment of this sorrow is part of what it means, not just to be Black in America, but also a Black person in Europe where I currently live. And it gets to a point of raising issues about who has access to care, who has access to gender-affirming surgeries, particularly for transgender people, a safe abortion, or the ability to access resources to seek infertility treatments, an array of challenges that is pronounced in this current age of COVID. And lodging between cultural wars over Black reproduction is a towering force of racial and health inequities that have persisted from enslavement and colonialism and into today. It's been especially devastating to witness how unequal the US healthcare system is, as multiple people have pointed out, especially with respect to testing and treatment. But it also has created a situation whereby the novel coronavirus has presented some pressing questions about Black reproductive health, especially given how financial insecurity and loss of work is overwhelmingly impacting Black Americans. So leading to 44% of Black people in the United States shifting their fertility preferences with a desire to delay or completely abandon the idea of pregnancy, compared to 34% of the general population. In addition to that, in this current moment, Americans across racial categories are wary of growing families. So the racial politics of reproductive health care is complex and is oscillating between people who are lacking access to contraceptives as well as to abortions, especially in conservative states, as well as those who might be seeking gender reassignment surgery. In addition to that, even when people are in a position to go to a hospital, according to the American College of Obstetricians and Gynecologists, they published a report in July last month indicating that Black and Latinx pregnant patients are more likely to test positive for COVID than their white counterparts. The statistics are clear and damning, but the root cause and potential solutions are not. In fact, if anything, what it shows is that the reproductive capacity of Black women and Black people overall is tied to a dark history of forced reproduction under slavery, but it's also tied to one of forced sterilization under Jim Crow. And if we want to address public health issues in this moment, it means attending to some of the work that has been done by groups such as the Black Women's Health Imperative and Fertility for Colored Girls, who debunk the myths about hybrid fertility and who also want equal access to all forms of contraceptive. That means in many ways, an anti-racist approach to Black health would ensure that reproductive contraceptives, assisted technology, gender reassignment surgeries is an essential part of public health policies. So turning back to Octavia Butler's Parable of the Sower, there has to be more that we can do, a better destiny that we can shape, another place, another way, something. The current social movements that we've seen played out on a global scale can help us to challenge this current pandemic so that we can imagine a new future. Thank you.
Wonderful. Thanks so much, Edna. Now I think Ruth has some comments prepared for us, and then we'll launch into asking questions, and then we'll open up to the Q&A.
Thanks very much, Emily. And thanks to all of you. You just gave fantastic talks. It's been a fascinating 45 minutes. So I would like to speak briefly about two general questions, which I think are relevant both to historical examples, which have come up throughout today and throughout the entire Epidemic Urbanism series, and also to today's situation. And as I see it, they play into not only how we understand the pandemic situation, be it many years ago or be it now, but also have to do with how the people actually involved in today's crisis approach their task and how they think about what they have to do. One is obvious and explicit, and you've all spoken about it, which is inequity, social inequity. But the other is implicit, but I wanted to draw attention to it, and you all have done so also implicitly, which is the absolute need for an interdisciplinary approach to whatever it is we're doing with regard to this and any other historic pandemic. And all of you have played into my talk beautifully with your examples, and Marie and Malo both talking about obvious inequities in the 17th century and in 21st century New York and London. Daniela with her story about Sao Paulo, Carlo with a story about the tremendous situation being undergone by refugees in southern Italy, and Edna right now with the questions of racial disparities and reproductive care. So let me start with talking about equity, or more to the point, inequity. In today's COVID-19 world, we see many obvious examples of inequity or possible inequity. Starting with the most obvious, who gets sick? You've all mentioned this again, either directly or indirectly. Who gets sick? Who gets tested? Both Carlo and Daniela spoke about access to testing. Who gets treatment? And in which hospital? There's the good hospital and there's the bad hospital. Who goes where? And this is an American concern, but who has health insurance? Although Anne-Marie mentioned in passing the National Health Service of Great Britain, clearly there are issues there as well, although not exactly on our level here in the United States. Who gets the vaccine once it arrives? Daniela gave a very interesting example about Sao Paulo. Which companies, and this is in the news literally today, which companies will get those very nice government contracts to manufacture the vaccine? Which university labs will get the NIH money that they need to continue forth with their research? So the decision-making process in formulating these questions implicitly reveal inequities. And they take us to what I think is a simple but key question, which is who decides? Who is in control? Who defines the boundaries and sets those questions? How do we formulate the questions? For example, do medical authorities or political authorities have the upper hand? Clearly they both do, but what is the relationship between those two? How do they share responsibility? And if we are talking about public sector or political authorities, we also have to talk about central versus local. That's a huge issue here in the United States, and I have to assume it is in other countries as well. In this country, it has particular peculiarities because of the current situation. But I think, frankly, even if the situation in Washington were not what it is, we would still have tensions between Washington, D.C. and state capitals, and at least in California, counties, which are playing a huge role. Similarly, who has the upper hand, experts or community? Again, clearly both, but how do we divide the responsibility? How do we separate between those who know a great deal and those who may have absolutely no formal knowledge whatsoever, but they're living a situation which perhaps those with many university degrees don't know about? So the answer to that question, or to that division of labor, reflects our conception of fairness, I think. And I think it's useful to be consciously aware of those divisions. Last week's roundtable discussion, part of it was devoted to colonialism or post-colonialism. And there's an obvious example where you have dueling sites of power. You have the colonial power that sort of landed in a particular place, and then you have the home country, and then you have whatever institutions were on the ground before the colonialists arrived. So you have three very obvious dueling sites of power. But even without a colonial situation, it is the location of decision-making, the physical, geographic location of decision-making is crucial and can reflect a society's notion of equity, its notion of who matters more and who matters less. And again, I think that it's important to remember that the question of equity, behind that question lies the question of control. Who is in charge? And what are the criteria? Going back yet another step, the formulation of those questions, I think, reflects our notion of the nature of the epidemic. And this is true today, but it was also true, in my case, I work in 16th century, but it's the same issue. We define the way we formulate our questions will reflect our understanding of what the disease is. For example, current example in the United States, meatpacking workers are dying in alarming quantities. This is not a question of a virus in their case. I mean, it is obviously, but that's not the point. The point, it's a labor question. It's an immigration question. It's a human rights question. And to think about it as a purely viral question makes no sense. So that was my first point in terms of how to think about inequity. And the second point leads directly out of that, which is the question of interdisciplinarity. And the meatpacking question is an example. The very makeup of all of the roundtables that epidemic urbanism has presented thus far point to the obvious necessity of bringing to bear knowledge and techniques from many disciplines and many professions. I think most of the participants thus far have been historians, or at least have degrees in history. But there's a vast number of fields that we all draw upon and that have been referenced throughout. And a short list would include sociology, city planning, urban planning, architecture, obviously. The organizers of this series have architecture degrees, political science, epidemiology, engineering, environmental science, public health, lab sciences, medicine, finance, and ethics. And I think all of these fields have been mentioned implicitly or explicitly today and throughout the entire series. These are not necessarily purely academic pursuits. They take us outside the university as well, which takes me back to my remarks earlier about decision-making. Decision makers in the public sphere must be able, government officials must be able to juggle all or many of these concerns and mentalities if they hope to come up with the right questions. For example, Malo at some point mentioned underlying conditions, and I forget exactly in which context, but that struck me because that is, you're going back a step. You're going back a step and saying, what are the conditions and how can we have to figure out what are not necessarily the academic interests, but what are the theories or the knowledge behind those underlying conditions that will allow us to take the next step forward. So then any attempt at any medical or social solution to the enormous problems we're facing today must be interdisciplinary, otherwise they will make no sense. And an example that Daniela mentioned struck me about the fact that, well, the Brazilian came up with this wonderful vaccine at long last, and it was wonderful and effective and all the rest, but that's all they did. All the efforts were placed on the vaccine, which is good for a vaccine, but it left, everything else was left untouched. And so that's an example of, you know, the city planners and the epidemiologists and the ethicists and the whoever else and the historians, because I'm sure Brazil had many other examples to draw upon in the past. If all the attention was placed on the vaccine, well, then no wonder in the long run, we're back where we were. So officials and researchers must assume that they must work not only side by side with people of different training. They have to learn to ask questions that do not respect boundaries and possibly ask questions of people entirely outside the professions altogether. Some of us in the academic communities, and I think I'm speaking for everyone here, are luckier than others in that we are housed or able to work in areas where we don't have those the silos that people always refer to, that we are allowed to wander among disciplines and approaches. And but there are government offices or departments that also allow that and encourage it, and some that don't. But I think my point is that it is essential to arrive at the proper questions, that environment be encouraged. So my hope is that the collaboration and encounters, such as the Epidemic Urbanism series and all the collateral activities taking place under that rubric, can help encourage other scholars and professionals who may be listening, policy officials, to try to work together to break down those disciplinary walls between us. And that is why these initiatives are so very important. So I think now we would like to turn it back to the five of you. And I'm hoping that everyone's papers, and possibly also my remarks on inequities and the formulation of questions, and then the question of interdisciplinarity, might have inspired you to come up with some additional thoughts to supplement perhaps what you said earlier, or to speak among yourselves. So I thought I would start by asking to what degree, I think it's implicit in, like I said, in all of your papers, but explicitly, to what degree did, as you were formulating this presentation or your work in general, have the questions, the need for interdisciplinarity, have you consciously grappled with that need? Or have you consciously reached out to people in other fields, or had a good experience or bad experience in that regard? So that's where I was hoping we could start. And then we can move on.
Well, fantastic. Maybe I'll just jump in real quick and then turn over to colleagues. Ruth, I really appreciated your questions, and certainly the focus on inequities, as well as the importance of interdisciplinarity. So I want to first start with, thinking about this broader perspective, certainly in the US context, and Edna certainly touched on, and other colleagues on the panel did as well. But if you look at the context of the US and who's being impacted, you see people being hit really by three waves. The first is COVID-19 itself, how it's ravaging communities of color and poor communities, or those who are less affluent in many ways in terms of resources and so forth. That's not a monetary thing, but also the access to different resources. And then you have the whole economic impact of this pandemic, is people losing their jobs, people who are still frontline workers, so they're working at home and they're working to help their children online learn, right, because schools are closed, and also going out and trying to keep jobs and multiple jobs. And then you have the issue, what I think is the heart of what you're getting at, is the power in racial dynamics. And to me, that is the third wave of looking at, certainly in the US, the anti-Black racist movements, the Black Lives Matter movement, the protests, to really get at that, who's at the table when we think about policing or developing our cities or thinking about vaccines or who gets tested and who doesn't. It's really trying to get at all of these things. It's not, obviously we all saw what happened with George Floyd, and this was police brutality as long has been an issue. We know this, but it's also a culmination of all these other things that people are saying enough is enough, and getting at these issues of the inequities, of who gets to decide. If we think about a true democracy, who is at the table and who isn't? Whose voices are heard and whose voices are not heard? Whose lives matter and whose lives don't matter? Were we talking about the migrant children who are being put in cages, taken away from their families, and how COVID-19 is impacting them? Or whether we're talking about the disproportionate number of people of color who are locked up in our prison industrial complex in the United States, which accounts for about 25% of the world's prison population. So I think that your point really struck a nerve with me, or it really made me think about this, in my own work, and sort of how all these are related. Now we think about these three big challenges, it gets naturally to the issues of interdisciplinarity. You can't talk about cities or pandemics without thinking about the complexity of the economy, history, the built environment, political science, public health, sociology, all the wonderful professions that my colleagues represent today, as well as people who are listening on YouTube. But it takes all of us to work together to really get at these issues. But for me, and why I do what I do, gets at the heart of what is the what is the sort of the foundation of a true democracy? How are people's voices heard, and how do decisions get made, and who's left out of that? So I'll stop there.
Should I go?
Yeah.
I would like to echo what Malo said. And in addition to that, I would, another area that we haven't discussed today, but that should be accounted for if we think about the relationship between epidemics and urbanization, is also incarceration, and specifically how those who are incarcerated have dealt with the coronavirus at exorbitant rates. In fact, the last statistics I read said that about 78,000 people in US prisons have tested positive for COVID. And some of the major breakouts have happened in places like Chicago, in the state of California, places in which Black and Latinx people are disproportionately targeted by the US police state. And therefore, what that means then is their family members, the people that they love and care about, don't necessarily have access to them, and or if in cases in which they're in a facility that is nowhere near their homes or in the actual cities that they're from, that impacts taxation, that impacts representation at the US Congress, etc. So in thinking about the inequities with respect to what is happening with COVID, there also needs to be a kind of honest conversation about the prison industrial complex. And as Ruthie Gilmore and others have written about, and making case for abolition is also making a case for public health, and taking seriously the work that ties, that neatly ties the relationship between what was Jim Crow and the new Jim Crow, as Michelle Alexander has written about, so that we can actually think about how to mitigate some of the outbreaks that have happened in US prisons, as well as here in Europe. I'll stop there.
Anne-Marie, go ahead.
To address sort of two of those issues, who decides, but also the historical context, I was wrestling with the understanding of what the social contract was in the 17th century that meant that England had just had a civil war. There was a newly restored monarchy. It was only that King Charles was only on the throne for 5 years when the Great Plague hit. So I was thinking about the essentially Hobbes Leviathan, Thomas Hobbes Leviathan, and that notion that the general public subordinated their own liberty to the head of state, who then had their best interests at heart for the commonwealth, the commonweal. And while I was wrestling with this, I almost literally reached across to my husband, who's a professor of health economics and has headed an interdisciplinary research unit for 20 years, 30 years, whatever. But he also sits on a government advisory panel. And so talking about the NHS in the UK and who decides, what ideas inform the people who make the decisions about who gets healthcare? Now, this is very specifically in the British context, but Britain has become more and more a neoliberal economy. And certainly the rationing body that he sits on is called the National Institute for Health and Clinical Excellence. It's called NICE. And there, scholars, academics weigh the cost benefit of any particular medical intervention. Now, NICE has not been directly involved in any way in developing policy with regard to COVID, but it will be with regard to the vaccines that are implemented. So he has no particular, he's not directly involved at all. But one of the notions that informs NICE is called the QALY. This is an economic concept. You may or may not be, Emily's nodding, the quality adjusted life year. Essentially, the example I would give would be my 23-year-old son and me, and one of us, we both have COVID, but there's only one medication. Who do you treat? Well, you obviously treat him because he will have a long life ahead of him, whereas I'm clearly destined for the grave. And that kind of economic model, I think, is very influential, certainly in Britain, in terms of deciding what interventions are made. So although there are very strict policies in place to make sure that people are impartial, nevertheless, there is a benefit analysis, a cost-benefit weighing up that's being made about who gets treated. And I think it's that kind of thinking that certainly in the British case underpinned the decision, the policy decision, to discharge elderly patients from hospitals without testing at the beginning of the epidemic into care homes, on the understanding that basically they were not going to, their QALY number was low.
Carlo, did you also have a point?
Yes, I wanted to thank you. I wanted to make to talk about the prisons, to remind what happened in Italy during the first days of lockdown in March, where there were prison riots, and there were like almost 10 people who died in not really clear circumstances, and they were their bodies were cremated, and there were not actually investigations, and we still don't know 3 months after it happened what actually happened in that situation. Also, there was a big discussions on media, on the Italian media, on the fact that given that you could not safely self-distance in prisons, there were like some mobsters, some mafia bosses who were elderly and with pre-existing medical condition who were sent to house arrest, and there was a big discussion by the fact that they were enjoying their life, but it was not the case, because as Edna and Malo said, the penitentiaries and prison system has to be rethinked, and the pandemic could be a moment in which we could rethink those aspects of our life. And now all the benefits that inmates had during the COVID outbreaks has been eliminated, and life in prisons has come back to normal. But this is something really interesting, because it was in a moment, it reminds me of Dr. Philip Zimbardo's thesis on the Lucifer effect, where those people who are incarcerated and those who are the guards are feeling their role more, and they're fitting into a role. And the same thing happened in the society, because there was a nation under lockdown, a nation on house arrest, and there were like those who had to guard the inmates had really a Luciferian effect, and there was some strange happenings. We were on the brink of a police state with the most strict laws implemented in during quarantine in Europe, in Italy. And it somehow stopped the pandemic, because we were the first country who were majorly hit in Europe. But it made even more strange today's situation, where to reboot the tourism industry, there is no control over anyone, and only illegal migrants are scapegoated as those who can spread the virus. And this is one of the things that have not been treated properly. Also, the reproductive justice Edna talked about in his intervention is something that in the 500 years ago by Giovanni Filippo Ingrassia were studied, and it was there was a protocol for women of all social classes to give birth with security. And there were also nurse rights that were respected, and there were like a change in nursery, and it was an aspect that was effectively taken into consideration more than now, probably, where, as we know, COVID is more, at least in Italy, is more of a healthcare and hospital infection, more than like an actual pandemic, if we look close to it. Something I wanted to add. Thank you.
Thank you. I wanted, if I could, I had a question for Daniela. And when you talked about how the development of the vaccine was really the only route that was taken in the 1970s, I found that fascinating. And I'm wondering if today in Brazil, there's any second thinking about that. Are researchers or administrators in Brazil talking explicitly about that as something not to do?
All right, so that's super complicated for a variety of reasons. So one of the complicating factors is that when the vaccine fixed the meningitis epidemic, Brazil was at a really hard time of like not having the infrastructure to make the vaccine in Brazil, despite a really long tradition of actually tropical disease and infectious diseases research and groundbreaking research since the early 20th century, because the military dictatorship had basically disbanded whatever infrastructure there was. Sounds familiar. And so what happened was, after having to pay, I think it was $40 million for the French vaccines, Brazil actually started to build the capacity to make vaccines. So now the question of vaccines in Brazil is now, and see, that's where it gets complicated, because I don't want to come out as like, you know, I don't think we should think about vaccines. I think they're really helpful. And so right now, Brazil, first of all, is one of the countries that is having the most testing of vaccines, because the outbreak is out of control. And so it actually makes sense to have volunteers there. So I think there's 3 vaccines right now that are being tested in Brazil, and that's a good thing. And the second thing is that we do have the capacity to make, and so the government is already making agreements with some of the, you know, the Oxford vaccine, and I think that's the one for sure, but maybe more that could be produced in Brazil. And so there's a kind of hope there that's tied up to a sense of like, now we have the infrastructure, and it's a good thing. So that's one side. And then the other side, in terms of, you know, the urban reform, since the 70s, when, you know, at the end of the dictatorship, and there was a lot, what started happening in the 70s, that there was a lot of movement around protests against the dictatorship, and also urban movements for like social reform. And it was coming from everywhere. It was coming from communities. It was also coming from the professions, like the urban professions. So architects and urbanists in Brazil are really engaged. And right now, when COVID started, even before, like everybody could see what was going to happen, right? So even before it got bad, all of these different architects and urbanists and academics started to do research and applied research projects and efforts with communities to improve the situation. And so you do have, and that's not, you know, that's not new. So you do have, from several decades to now, an effort to address those really bad conditions with really creative thinking, in terms of, you know, you can't just demolish all the shanty towns and build modernist housing on top, right? And so there's a long tradition of improving those communities, and understanding that, you know, a vaccine, we have one for COVID, it's going to fix COVID, but there's going to be a next pandemic, and it will be a different issue. If we had had this conversation maybe a couple of years ago, when we had a different government and we were talking about different health crises. So we had, in the last decade, issues with yellow fever, dengue fever, and Zika. And actually, the government was able to come up with all these different solutions to control mosquitoes and improve sanitation. And so you actually do have a lot more of that thinking of, you need to do other things, not just the vaccine. But the problem is, first, the problem is just so big. I mean, São Paulo has, you know, just 20 million people in the city. These neighborhoods are so gigantic that it's just very hard to just address all the problems because of a matter of scale. That's the first thing, even when you have political will, which we had up until a few years ago. And now we have a president and lots of state governments that like don't want to do anything about it. And so you have a series of different conflicting forces that you know, try to do something, have some success stories, but they sometimes can be very small scale.
Thank you.
If I could jump in with a quick question. Also, I just want to encourage anybody who's watching to submit questions as well, and we can ask them of the panelists. The one I was thinking of is just, Daniela kind of sets it up perfectly, and I wanted to kind of broaden the points that you were making to the rest of the panelists, which is about crisis thinking and long-term solutions in pandemics. It seems like a commonality across these presentations and also across presentations from other symposia related to epidemic urbanism is that epidemic disease exacerbates and highlights these kind of long-term inequalities and long-term infrastructural problems that exist in cities. But because of the intensity of an epidemic, most of the mitigation ends up being in crisis thinking mode, in these kinds of short-term solutions, like the vaccine. And then you have these kind of underlying infrastructural problems that continue to be problematic and become problematic again during the next epidemic. And so the question I kind of wanted to ask all the panelists is, how can we conceptualize of a kind of urban space, or in the cases that you look at, how can we think about ways that long-termism can be incorporated into epidemic response that mitigates many of the issues that we're talking about here?
Well, I think that's a fundamental question. Certainly these are things that this is a kind of question I grapple with all the time, like I'm sure many of you do. As we think about the crisis right now, whether we look at New York City or Chicago or Los Angeles, Atlanta, we're having those conversations about how do you think long-term. Unfortunately, with many of our elected officials, and you know, this goes for whether you're a Democrat, independent, whatever it is, you're often thinking about your next election or your next thing, and we have to think long-term, right? And so I sort of think it's important to engage the populace. I go back to Ruth's question around inequities and who gets to decide. And I think a foundation of a part of this is organizing and community building, and of saying, what is the kind of city that you want to see? What does an anti-racist, healthy city look like? What does a city of opportunity look like, right? And so you have to engage all people in that process. And it's not for one person to decide or one elected official or whatnot, but it's really about developing processes that allow for more people to have a say-so in the process. And then what are the outcomes, right? And ultimately it gets down to implementation. And you'll hear policymakers say, oh, well, it's gonna be so expensive, it's gonna cost this. But in fact, it's about priorities. We spend money to bail out Wall Street, we spend money to bail out big corporations or what have you, or put it into vaccine development, which is obviously important, but we have to think about how do you weigh the pros and cons of all these things. And if we were to invest in community and invest in people long-term, the cost savings are overwhelming.
Can I go or?
Yeah, absolutely.
Okay, I would also echo many of the comments that you've made, and I think that some of the long-term solutions have to be structural ones that are put into place that prioritize people over profit. For example, economic relief for people who are struggling in this moment, especially those who are unemployed, without, strings attached, so that those who haven't necessarily put it into the quote unquote system can still benefit. So here in Germany, for example, immediately in the beginning of the lockdown, in March, there were 5,000, the government gave out 5,000 euro emergency grants to anyone who had a German bank account, Steuernummer, and was registered. And so that made it easy for even foreigners to have access to those funds if they needed it. Also, there has to be a serious conversation about instituting universal basic income on a global scale, not just in the US context, and as well as an income maximum. So there's no reason that Jeff Bezos should be making as much money as he does and profiting from other people's labor. Guaranteed housing would be another thing. So building more social housing and making sure that it's available here in Berlin. There have been movements to ensure that there's more lower rent within the city, and legislation put into place to make a Mietendeckel, which is like a rent cap or a ceiling cap. I would also add too, and there's been conversations by politicians like Alexander Ocasio-Cortez, as well as people here in Europe, a new Green Deal that would make develop environmentally friendly jobs, policies, and other things to mitigate many of the issues that have arisen as a result of the climate crisis. And then finally, too, defunding the police and military and using the money that is often spent for those purposes towards education and actual public health infrastructure, so that essential workers are protected, and that masks, hand sanitizers, and other kinds of protective gear are readily available when people are working. So yeah, that's it.
Thank you. It's so nice to hear concrete interventions and ideas. I think those are exciting things that can come out of conversations like this. I want to make sure that we get around to questions from our audience. Farna Zernabov asks, how do we incorporate the voices of the communities affected most? Which I think is also a nice jumping off from the previous question. So Daniela?
So, I mean, I was super excited to see, Farina posted 2 related questions that phrased this, and this is so relevant in the case of São Paulo. And, I came at this project on the epidemics from my longer term project on grassroots urbanism in São Paulo in the last 2 decades. And so I've been looking at communities and social inequality for a while, except that public health wasn't a big issue until now. And so we do have, first of all, generally in terms of social equity and grassroots initiatives, a lot of examples in the city and how to support them. So I'm going to talk generally and then bring it to COVID. And so generally, the one thing that I've found in my research is that unlike in other places where people really separate like do-it-yourself urbanism from the government as this kind of like, plugging the hole or totally separate thing, in the case of São Paulo, it's actually not that separate. And I have found that grassroots urbanism in many cases thrives and sometimes even starts because of public policies that are there that are aimed at equity and redistributing wealth and resources. And that the government, when we have progressive people and long-termism in mind, has actually implemented all sorts of different ways of supporting with resources, money, the communities who have ideas in a very decentralized way. So it goes to, I think, Ruth's question about, who has a say and how do we balance out the experts who are trained, let's say the urbanists, with the people who live in the communities and not only have an idea of their lived realities, but also when they come up with really good ideas to address those realities, it comes from a place that gains more trust than if someone comes from the outside. And so bringing that to COVID, it was super impressive to see. I mean, I'm finishing this project, I'm writing the book now, and it was, I knew that there was already an infrastructure in terms of community organization when COVID hit. And it started to work in many small scale things like people distributing food and medication, crowdfunding, making masks in some of these communities. But there's this gigantic success story, which is there's one shanty town, there's one favela in São Paulo, Paraisópolis, which is one of the largest in the city. And everybody was forecasting this catastrophe in all of these favelas, and many of them have been horribly hit. But in this particular favela, what they did is that the community, which was already organized, created this kind of front in which they had a centralized organization within the favela where they pooled resources to charter ambulances to roam the favela. The public schools had been closed, so they petitioned to use the public schools as isolation and quarantining space because they know that people inside their dwellings wouldn't have that space, so they could safely quarantine. And they also instituted the system in which each street in the favela, and street, in the favela, the street can be just like a tiny little, passageway, right, between these really tightly packed dwellings, but each street had a kind of street president that was responsible for monitoring the situation, for making sure that people had what they need so they didn't have to go out, to keep a tab on cases. And so, after a few months of that, basically you have like this average for the city of São Paulo in terms of deaths and cases. And it's very bad, the average, but it's also very unequal. And so the wealthier neighborhoods are doing a lot better, like sometimes 3 times better than the poor neighborhoods. But what happened in this favela is that it got better than the average. So we started to have good results, like comparable to the ones in wealthy neighborhoods. And so to me, it's on the one hand, this kind of really moment of hope, of understanding like the power that can come from these communities. And to me, it's really a power of knowledge. It's a different kind of, like it forces us to think about epistemology, right? And what do we value as knowledge and expertise? But at the same time, I feel like it's not fair that they have to do it for themselves, right? It's not fair that these people, and these are people who have full-time jobs, and some of them were out of work, some of them kept working, and that's why they kept getting COVID, because they keep circulating in the city. But it's not, they have jobs, they're participating in the city's economy, and they still have to, in their free time, organize themselves to do this work that I don't have to do. Like, I don't have to keep a tabs on my street, you know, and charter an ambulance to serve me. And so it's sort of like this kind of bittersweet. And I think maybe to the question, you know, the question is really asking, how can we support? I would say we have to listen and provide the resources and listen to their knowledge and bring them to the table as a different kind of expert. But we also have to provide the conditions so that they don't have to do that labor, that they can be in the table as experts and decision makers, but we are rewarding the labor, we're paying for this, we're bringing other people to do that work.
It's worth noting that similarly, there was a story out of Mumbai, India, where they talked about how Dharavi slum actually has one of the lowest rates of COVID infection of any neighborhood in any area in the city because of strong community organization and similar structures to which you're talking about in Sao Paulo, which is really fascinating. So it looks like we have an answer. Wonderful. Yes, and Farina makes the point that, of course, we also have to think about the fact that we need the rich to help the poor, and fundamental inequality is going to exacerbate these problems either way. Do we have any other questions, or anyone else want to answer that last question before we move on?
Yeah, just to note that what Daniela said for the favelas of Sao Paulo happened also in the poorest neighborhood of Palermo, where grassroots organizations, or as Professor Fariba Zalinabov said, there was a community effort to help those who normally struggle in a poor part of Europe, and there was this kind of help that it was yes, something positive, but it was also motivated by the fact that there was a lack of the public and the mayors and the national help for those in need. So it was something that was filling a void in helping families and whole neighborhoods, all streets that they could not afford to eat actually without their daily jobs. They were all closed because of the pandemic. So yes, it is sure something that create communities and create connection between communities and different parts of town. I have experience of friends who went to poor neighborhood to give to the poorest part of town to give aid, and they were shocked because they could not imagine that there were people living this condition in their city. They did not have experience of those neighborhoods. So yes, it was something that built a sort of network of help and of positive action, but it was also something that should have not been put in action by normal citizens, but the mayor, the city council should have done more because there are resources, but they were not spent to help those in need. It's pretty similar situation to Mumbai or Sao Paulo. I just wanted to notice that.
I wanted to add something to that, which both to Carlos and Danielle's comments. It seems that in cases where communities have managed to put together some sort of a response, sometimes sometimes this points to a failure on the part of central authority, but sometimes also on the strength of the local authority. In the case Daniela mentioned, I think the reference to the 1970s and post-dictatorship community organizing is fundamental, that these communities or neighborhoods had, let's say, 20, 30 years worth of political organizing and political consciousness, the development of some sort of an intellectual or political apparatus in their heads that gave them tools later on at the moment in terms of coming up with these ideas of the school, the quarantine, the ambulance, etc. But you need some sort of a foundation. My research, as I said, is 16th and 17th century Spain. Similar things happened there, but there the sort of the defining mental apparatus was Christianity. And so you had a sort of a set of terms or relationships or guarantees that were basic to everyday life. And so organizing along neighborhoods and community aid and mutual aid and all of this worked. I mean, it certainly worked on the smallest level, but people had some sort of a mindset which enabled them to make those steps. Sometimes I wonder if today, at least in the United States, there is there's a vacuum there. That we don't have. I mean, you see people grabbing onto ideas from the Constitution or the Bible, but it usually doesn't make much sense because, not because the Constitution and the Bible don't make sense, but because they haven't been thought through and lived through. They are not part of people's daily lives, and they're not the tools that people use every day. So I think Daniela's example is very instructive, that you had those decades of community organizing that then enabled people to move when they needed to move now. And I think in Italy, you may have similar examples. I'm guessing that that Catholicism maybe fills some of that gap, although I don't know. Certainly there are cities in Italy with years of communist governments and or progressive governments, and that's probably also true in most countries, where you have decades of governments that allowed participation and used a discourse that was picked up and understood by common people. Those are tools that now are becoming crucial. But in the absence of those tools, that's when you have chaos or stasis. So,
for the next question, I'm going to try to combine two very interesting questions posed by our coordinators about inequality in academic research settings and how it affects the research that's produced, and also then a question about censorship. So taking that academic research out into the world and how those two things are kind of being fundamentally challenged by epidemics. So first, this kind of question of inequality in academic research between fields, in diversity also in research, and then once that research is kind of created, the barriers to its dissemination in epidemic control.
I think one thing that has to be addressed is the crisis, the neoliberal crisis in academia overall, and what that has meant with respect to the lack of adequate, secure employment for a new generation of scholars, in a way that people either have to leave or have multiple kinds of jobs and just these short-term positions. So for people like myself, where contracts end like after a year or two, and then it's just from one thing to the next, it creates a problem as to who is able to do scholarship. So there's that question about job security within academia. And the second thing too is like, what is the content? And the kinds of questions that people are able to ask with respect to decolonizing universities and making universities accountable for the legacies that they are built on, whether it's the colonial, settler colonial legacies, enslavement. Princeton, where I got my PhD, the structure of some of the housing, student housing, was basically slave quarters. Like they would have, white people would bring their Black slaves to live and come with them to the campus, and that legacy is embedded into the structure of the institution. And in some cases too, even here in Germany, at the Charité, which is the medical hospital, one of the oldest public hospitals, they have skulls from people who are Herero from Namibia, and those skulls were taken during the German colonial period in Namibia. So acknowledging how these academic medical institutions have not only been built on colonialism and slavery, and reckoning with that is going to be something to deal with those inequities. And then outside of that, there just also needs to be a democratization of knowledge such that people are able to not have to have paywalls or pay for learning, and have access to physical institution and buildings, so that it's not just for the elite. I would say that, yeah, and this current pandemic is teaching us that a lot of things can happen online, that we don't necessarily need to have border regimes, and that it is possible to have the knowledge that is truly horizontal as opposed to what it has been up to this point.
I think there is also a danger, and I'm out with the academy. I mean, I'm fortunate to be an independent, but there is a danger that institutions might exploit what is already a precarious group through being able to teach much more cheaply by doing it online. So there needs to be a balance struck between in-person and remote teaching. And I know there were issues, I think, with regard to dreamers who were not going to be allowed to remain in the United States if they could have online tuition. And Berkeley, I think, developed, correct me if I'm wrong, developed a policy whereby every student had to have an in-person contact hour, at least one a week, which meant that they then couldn't be effectively deported. So I think, although there are fantastic opportunities and we're benefiting from it now, we just need to be a little bit cautious about the joy of Zoom.
Yes, understandably so. Oh, Danielle.
If there's time, I know we're sort of, is there time for like quick word on censorship? So, you know, one thing that was really strong in my historical case study during the dictatorship in Brazil was censorship, because that was going on. That, you know, the military dictatorship at the point in time was routinely persecuting and oppressing people who dissented, and censoring news, including news of the epidemic. Like, reporters would go and interview the Minister of Health, and then a few hours later, the newspaper would say, no, you can't publish that. And then they would just publish a recipe or a poem in the place where that news story should have run. But what is really kind of, you know, eerie is that there's some echoes of that, both in Brazil and in the US. In Brazil, there was a few months, I can't remember if it was like a few weeks in maybe May or April, where like the data was so bad coming out of Brazil that the government closed all the information and then changed how it was giving information. So you would go to that famous Johns Hopkins COVID map, and for a few days you couldn't see Brazil because the information wasn't being fed there. And then it returned, but everybody was panicking. And, you know, there was a lot more information actually that I could find earlier on the pandemic. I'm based in the US, that now it's become harder. So that kind of control, you know, is going on again in a supposed democracy where we have a president who, you know, has done a lot, like he's militarizing our government, and he's done a lot of things to make us fear that it won't be a democracy for very long. And I think there's some parallels with the US, and including people who were fired from their jobs in Florida because they were trying to publicize data in a certain way. So I'll leave it at that, but say that, you know, it's really sad to see that this thing that I thought was really a past chapter in history is coming back, and in a way that's not overt. And so in a way, it's even harder to fight it if, you know, we're supposedly in a democracy.
Yeah, and this is perhaps a very depressing note to end on, but there are kind of two levels that we're talking about here. One of which is that within the academy, fields that are driven by data and statistics are the primary ones that are receiving funding, especially in the wake of COVID, which means that many of these more long-term implications that we've been talking about are really being dampened in the world of academic research. And then even the statistics and information that are coming out of these granting organizations are being manipulated by governments to assume some form of control in international posturing. And so we see this kind of interesting double layer of censorship that's both monetary and non-monetary. I think Mohammad wanted to say something, and then I think we will conclude.
Sure. Thank you so much, Emily and Ruth, for doing such an amazing job moderating this session. And thanks to Malo, Daniela, Anne-Marie, Edna, and Carlo for your wonderful presentations. And of course, thanks to my colleague, Caitlin. So Caitlin and I would like to thank all of you. And again, feel free to check our YouTube channel, because we'll be posting this video there in probably a couple of hours. And more interviews with visionary scholars and practitioners will be coming there. We'll be uploading there. So thanks again, and all of you have a wonderful weekend.